Good evening, everyone. Welcome you all to Oncology Classroom. This month, we are discussing on pediatric oncology, and today we are going to discuss on management perspective of pediatric ALL and AML. This lecture will be given by Dr. Amita Mahajan, who is a senior consultant pediatric hematologist and oncologist, and currently working at Indraprastha Apollo Hospital, New Delhi. Dr. Mahajan has also served Landau Hospital, Cardiff as a consultant, and she has been trained from prestigious All India Institute of Medical Sciences, New Delhi. We are thankful to have Dr. Mahajan today evening with us. Let us all welcome her. Thank you, ma'am, for being with us. May I now request you to please take over the session and start your lecture. Thank you.
A very good evening to all of you. Dr. Mandal has kindly introduced me, but I'd like to start at the outset from saying that it's really a privilege and pleasure to be at this platform. This is my first opportunity to join you at this platform. I'm going to take you through a journey in pediatric ALL and AML today, but I'd like to reassure you that I'm very cognizant that most of you are from a radiation oncology background. Unfortunately or fortunately, whether you like it or not, at many centers in India, radiation oncologists still have to manage pediatric hematological malignancies. Also, a number of principles of management of pediatric hematological malignancies are equally applicable to adult hematological malignancies. In fact, for many of them, the protocol is exactly the same. So, over the next few minutes, I'll take you through a journey of pediatric ALL and AML, and please feel free to post your questions, and hopefully we will have a time at the end to interact more freely. One might think, well, we have so many topics in adult oncology, pediatric oncology is so rare, why do we need to even bother it? Yes, it's much rarer, but it's not so rare. Every 3 minutes, somewhere in the world, a child is diagnosed with cancer. Each year, this amounts to more than 250,000 children and adolescents, and 20% of these happen to be in India. So that makes it our burden of about 50 to 60,000 new children with cancer in our country every year. 1/3 of this is acute leukemia or hematological malignancy. So actually, I have a very daunting task of covering 1/3 of all of pediatric oncology in the next 45 minutes or so. So it will be a bird's eye view, but hopefully I can communicate to you the success story of childhood leukemia. So let us start with acute lymphoblastic leukemia. And I'd always like to start a talk on ALL with this slide. The successful treatment of acute lymphoblastic leukemia is actually one of the most compelling stories of modern medicine. And it's not just about ALL. A lot of how we practice oncology, the principles of medical oncology today, we have learned from the lessons that we learned during the evolution of management of acute lymphoblastic leukemia. This graph that you see is actually the treatment outcomes at one particular center, St. Jude's, which is the apex of Center for Pediatric Oncology. And you can see era-wise what is the successful treatment of acute leukemia. And currently, if you receive optimal treatment, the chances of a child being completely cured of ALL is approaching 90%. It is the commonest pediatric malignancy. Its peak age is 2 to 5 years. About 85% of patients will actually be a B ALL or B lineage ALL. Why does it happen in such young children? I mean, it's not a lifestyle related disease. Why do children get it? And we go back to the Knudsen, hypothesis that it is a number of mutational hits that are needed to develop a malignancy, especially ALL. And you need a minimum of 2 hits to develop this malignancy. This philosophy is there for virtually all malignancy, but it's best exemplified by pediatric malignancies. The striking thing about pediatric ALL is that you are actually maybe born with one of the mutations that finally leads to the development of ALL. So interestingly, TEL-AML, or what we call ETV RUNX1 mutation, which is the commonest abnormality seen in ALL, cytogenetics, is actually present in 1% of newborns at birth. But not each of them will go on to develop cancer. AML-ETO, the commonest abnormality that we see in AML, is seen in 0.2% of babies at birth. And these studies have been done on the the neonatal screening filter papers that are done for other things. So the basics may be there really in utero, but you need more events to happen before a child or a young baby develops leukemia. So again, this just shows that there is, the initiation or the first trigger or hit may actually happen in utero. So if you look at, congenital acute leukemia, there is 100% concordance with the other twin, because you need perhaps only one hit, and that hit may have happened in utero. So the first trigger happens very early, but you need subsequent events postnatal. And these may be, due to a number of mutations, to a number of environmental triggers, and that may lead to acute lymphoblastic leukemia. When we talk of pediatric ALL or adult ALL for that matter, it is not one disease. Increasingly, we are understanding that each child is different, and they, depending on what mutations they are, the ALL has. And that is why increasingly we are moving to a more personalized style of medicine, as you are doing in other spheres of oncology, and targeting some of these mutations specifically. So I'd just like to very briefly take you through this, successful journey of acute lymphoblastic leukemia. In 1940, it was a uniformly fatal disease. And much of what we have achieved in ALL, it's really come in the beginning, because it was very frustrating. You see these young children dying, whatever you did, they just died. They were allowed to just be in a dark corner because you knew nothing will work. But there were few committed people who never accepted defeat. And that's like, the foundation of all of oncology. In 1947, aminoterrin was synthesized, and you could for the first time actually get ALL into remission. And this is when the era of leukemia therapy or all medical oncology began. In 1950, Faber from the Dana-Farber Cancer Institute tried ACTH in leukemia, and again it seemed to do something to it, and that's the foundation of using steroid for every single child for ALL. In 1951, we had 6-mercaptopurine in our hand, and it is a drug that we still continue to use and forms the backbone of ALL therapy. In the era of 1952 to 1962, we started having systemic trials combining chemotherapy, really inspired from tuberculosis. But at this point, our 5-year event-free survival was approaching only 3%. In 1960 to 70, some other drugs were introduced: asparagine, daunorubicin, cytarabine, and etoposide. And really from 1970 to 2020, we have had no new drug in acute lymphoblastic leukemia. And our outcomes have changed from 20% in 1970 to nearly 90% today. So how did we get there with no new agents in our hand? And I think because a number of the attendees today are students, this is something to be inspired from, that how we can use what we have already to improve outcomes dramatically for a number of other diseases. This is a clip of some of the first scientists who dramatically changed the outcome of ALL. This is a slide from St. Jude's archives of the first 5 or 6 people who worked so dedicatedly towards this cause. So how did we get to such improving outcomes without any major new drug? So that is because we learned so much from national and multinational randomized controlled trials. Today, the world of clinical trials is really overwhelmed by adult oncology. But to begin with, the first trials were actually done in pediatric oncology. We now understand the biology better. Like I showed, that we need to do it, different patients may have different forms of ALL, and we need to understand them well to treat them appropriately. Pediatric oncologists are really, sometimes we were, most hated because we are so sticklers that there's a strict adherence to a structured approach. increasingly we are using risk stratification, response adapted treatment, and that is the current paradigm for ALL treatment. Finally, there have been dramatic improvements in supportive care over the last few years, but still in many centers in our country, more children die of toxicity or complications of treatment than due to ALL itself. So we in India still have to go a long way before we can match these outcomes at each and every center in our country. So when we see a new child with ALL, how do we go about working up? Morphology continues to be still very important. But finally, we need to confirm that by flow cytometry, because we need to know what is the immunophenotype. And we need to know more about the cytogenetics. We need to know the karyotype and some molecular tests. And if we are working in a very resource constrained setting, we should still at least do the Philadelphia chromosome, because even in children, a proportion of children will be pH positive and their outcome will be severely compromised if imatinib is not added. If you have the luxury, some centers are even going into genomic sequencing for every child with ALL, but it is not truly necessary to manage them optimally. So what are the current protocols for acute lymphoblastic treatment that are followed anywhere in the world? We have the Children's Oncology Group protocol, we have the BFM protocols from Germany, we have the UCAL protocols from UK, St. Jude's protocol again from US, we have the Italian protocol AIEOP. Finally, we have protocols that we are now following. So in India, many centers follow any of these international protocols, but MCP 841 was the first protocol, and it was a common protocol for both children and adults that laid the foundation for protocol-driven treatment in India for all of medical oncology. It was ALL, but it really, set down the principles of medical oncology in India. But over the last few years for pediatric patients, we are using a protocol, a collaborative protocol that is being followed in many centers in the country now, which incorporates the modern principles of treatment and is known as ICICL. It is an Indian Childhood Cancer Collaborative Study. So whichever protocol we follow, it incorporates the same drugs. And there have been marked treatments across the board in all of these collaborative groups, based on the reasons that I have just explained. The protocols follow different philosophy and slightly different scheduling, but exactly the same drugs, and the results are comparable in similar settings. So as a center, it is up to us to decide which particular protocol that will be most suitable for our center. Some may have more intensive induction. So if our induction mortality is already high, that may not be the best protocol to go for. While other protocols may have more intensive intensifications or more intensive maintenance arms. So it is, for each center to see what is the best protocol that will suit them. How do we risk stratify children with ALL? So age and high white cell count have continued to be very important features despite all the newer, techniques, and we call this as Oxford Hazard Score. So children between 1 to 10 have the best prognosis. More than 10 have, inferior outcomes, but with appropriately intensified treatment, their outcome is similar to the standard risk count. White cell count more than 50,000 is considered to be high risk. T cell automatically goes into the high risk count, while B cell, which is the predominant cell type, is the standard risk type. Presence of CNS or testicular involvement at the time of diagnosis is labeled as high risk. Presence of Philadelphia chromosome and certain translocations such as MLL or hypodiploidy on karyotyping, the early T precursor, certain specific subtypes automatically go into the high risk arm. So the treatment is stratified most protocols in standard risk, high risk, and very high risk arms, or some centers may call standard risk, intermediate risk, or high risk. Finally, response to initial therapy. That is the most important feature for virtually any oncological condition. But for ALL, the measurable or minimal residual disease is the most important thing that identifies the prognosis of the child. So what are the components of pediatric ALL treatment? So we may or may not use a steroid pro-phase. This is followed by a 4-week induction, followed by consolidation, delayed intensification, and then a very prolonged phase of maintenance. CNS prophylaxis is an integral part of pediatric ALL treatment, and we see this in every point that, throughout the entire treatment. So what about the steroid pro-phase? Not all protocols incorporate steroid pro-phase, but it is the response to initial 1 week of steroids, which is usually prednisolone, is a very important prognostic indicator. This has been adapted from the BFM protocols, but a lot of other protocols use it as well. In our country, we almost always use it because it actually helps us to stabilize the patient as well. And we have observed that if we use a steroid pro-phase, apart from seeing the steroid response, we actually see reduced transfusion requirement and toxicity when we actually start the myelosuppressive induction. So this is an important phase, but if it's a stable child, not everybody needs it. It really depends on the protocol that you are using. Then we go to the 4-week induction. And here we differ from the adult protocols because all adults will actually receive a 4-drug induction, which is vincristine, donomycin, steroid, and L-asparaginase. But for pediatric protocols, most protocols will use a risk-stratified approach. So patients with standard risk or more favorable disease, younger patients, less white cell count, will actually not receive donomycin in induction. And that it makes their treatment much simpler and reduces the toxicity significantly. So patients who have favorable disease or standard risk disease, their outcomes are equally good for 3-drug versus 4-drug. So the protocol that we are very widely using in India now also uses this philosophy. So for induction, we all know that steroid is the drug that every single protocol will use. So which is the better steroid? And prednisolone has been the traditional steroid. Dexamethasone has been around for the same time, but we know now that dexamethasone is a superior steroid for acute lymphoblastic leukemia. Normally, when we give substitute prednisolone with dexamethasone, we just make it like 6 times more, which is the equivalent of their glucocorticoid and mineralocorticoid activity. But we know now that the lymphocytotoxicity or blast killing activity of dexamethasone is actually 16:1, while their other activity is 6:1. So it's no wonder that dexamethasone is superior. Randomized control, large number randomized control trials have confirmed this, and most protocols will use dexamethasone for induction, specifically in TALL. However, it is more myelosuppressive and the toxicity on a number of areas is more, especially in older children and definitely in adults. So most adults will still stick to prednisolone, while some may use Dexona, at least in young adults. Anthracycline, like I said, is again an integral part of induction. Patients with favorable disease may not need it, but all high-risk children will get anthracycline. And donomycin is the conventionally used anthracycline. So why dono, why not doxo when they're, virtually equivalent? So data on, the 2 drugs in terms of efficacy is similar, but there is, it has never been studied in a very randomized fashion, but there is some data that doxo is actually more myelosuppressive and causes more mucositis associated with more toxicity. So actually in induction, we use donomycin, but in delayed intensification, we do use doxorubicin. So what about asparaginase? Most centers in India still continue to use conventional E. coli asparaginase, which needs to be given every 48 to 72 hours. It is more efficacious if given, intramuscularly compared to intravenously. But most developed countries have switched to the pegylated version of E. coli asparaginase. It doesn't really matter which one you use. The aim is to achieve sustained asparagine depletion. Asparagine is an amino acid which human cells have the capacity to generate, but the blasts cannot generate themselves, so they need the asparagine. So if we can actually deplete asparagine for more than 2 weeks at a stretch, that has significant blast killing effect. And we need to actually have a serum level of asparaginase more than 100 to have a sustained depletion of asparagine. The pegylated versions that are currently available, they can replace up to, so they are effective for about 2 weeks, and they can replace 6 doses of conventional asparaginase. So is it necessary to use pegylated version? No, not really. What are the advantages? It has, of course, acts longer. So you don't have to subject young children to painful injections. They no need to come to the hospital so many times. It's also less immunogenic. So there is less anaphylaxis and less chance of silent inactivation due to antibodies. So a number of patients, if we were able to screen them, who develop, as who are on asparaginase, actually develop antibodies which neutralize the effect. And this is much, much lesser with pegylated version. Unfortunately, we have not been able to demonstrate, a difference in efficacy, even though theoretically it seems that it should be more efficacious. And currently, all protocols in India, now we have a number of generic versions, but only one of them has been formally tested in a randomized fashion, the first brand generic version, which was introduced in India. And we know that for a fact that is equipotent and has similar toxicity to the innovator compounds. So what is the most important thing after induction is to see what is the response. And this word minimal residual disease or measurable residual disease, we use it for virtually all hematological malignancies today, whether it is CLL or myeloma, but it's, the most impactful outcome is seen in ALL. So this is one of the first studies that showed that if you were, the first line on the top, if you were MRD negative, which is less than 1 in 10,000 cells in the bone marrow at the end of induction, your outcome was 88%. But if you had more than 1%, the outcome dropped down to 30%. It's not an absolute thing. So your outcome depended on what was the measurable residual disease in the bone marrow at the end of induction. You can test it at any time point. You can do it at day 8. And again, you can see if you were negative in the peripheral blood for measurable residual disease at day 8, outcome is 90%. If it is more than 10% on day 8, your outcome was less than half. Again, if you combine the two, it becomes even more impactful. So a number of studies, there's so much data on this subject that currently the measurable residual disease at the end of induction trumps all other known prognostic factors. Just a reminder that for TALL, end of induction may not be the best time to measure ALL, and perhaps measuring it at week 12 is the most important predictor for relapse in patients. And a treatment escalation for TALL is usually done after assessment at week 12. So it's very good to know that, okay, it's, it predicts response, but what can we do with it if we have a bad MRD? So there is evidence now that if we escalate treatment for patients who have bad measurable residual disease, it can improve outcomes. So this is the UCAL 2003 data, which showed an improvement of about 4 to 5%. Now you may think, well, these curves look so closely spaced, but when your outcomes are already approaching 85%, really you will have increment outcomes only in 4 to 5%, which is a 10% improvement in survival. Well, okay, it is good to escalate, but for a country like India, what we would really like to know that can we actually de-escalate treatment for patients who have very favorable MRDs? And yes, there is data for that. So until recently, we were actually giving 2 blocks of delayed intensification. But then for patients who were MRD negative, they were randomized to have just 1 block versus 2 blocks, which is actually the most toxic component of treatment, and they did equally well. So yes, you can de-escalate, you can use it to de-escalate treatment as well. This again was re-emphasized by the Dutch data that based on this, if you, for at least 25% patients, you could de-escalate treatment. And when you escalated treatment for those with unfavorable things, an escalation may mean transplant, the outcomes could be changed from 16% historical controls to 78%. Again, for whatever reason, either relapsed disease, refractory disease, if you had to take the child to transplant, their outcomes really depend whether they were MRD negative before going into transplant. So in the current era, we would work very hard to actually make them MRD negative before taking them to transplant. And the BFM current, basically, it only uses MRD as a prognostic tool, and it tests it at 2 time points, at week 5 and at week 12. And your prognostication and your treatment escalation is based entirely on the MRD status. Some of you may think, well, in our country, it is so difficult to even get a flow cytometry for diagnosis. How and when can we afford MRD for every single patient? So definitely it is something that we should strive towards, because the economic analysis actually shows that though we may have to spend some money on it, it's a very important tool. And it is for this reason that as part of a support group, we organized to offer MRD to any child anywhere in the country who needs it. So 2 very dedicated, very prestigious labs. And before we set out this project, we actually validated even these 2 labs with one of the best labs internationally. So we could offer free of cost MRD assessment to children with ALL in centers which did not have these facilities. And you can see that, these samples traveled nearly 400 kilometers to reach under suboptimal conditions. But most, virtually 99% patients, the samples were viable, and the results mirrored, which is the international result, that about 70% were negative and 30% were positive MRD. And could we actually modify treatment? So you could see that, the treatment needed to be escalated in the 30% who were positive, but we could manage to escalate it in about half because of the logistic constraints in those centers. And this is something that we are still working towards. Similar data with MRD has actually been seen in the adult groups. This is the GMOL data. So it shows that, those who had high MRD, if you did not escalate their treatment with BMT, outcomes were dismal, but when you did it, the outcomes improved. And similar things with all the, the series of the GRAL studies in adult ALL have shown the importance of MRD in adult data. The most important thing is that for pH negative patients, if they were MRD negative, transplant in adults did not offer additional advantage. I'm just sharing some adult data because I know most of you are from adult background. And again, for Philadelphia chromosome positive ALL, whether in children or adults, measurable residual disease analysis is now the most important indicator. So for a child with pH positive ALL, if they were MRD negative, we would not be taking them to transplant. So let's talk about consolidation and intensification. The backbone is inspired from the BFM strategy of use of cyclophosphamide and cytarabine. In pediatric protocols, the children with low risk disease actually do not get very intense consolidation. Systemic methotrexate in some form or another, depending on what protocol you are, the dose may be 1 to 5 grams per meter square, is extremely useful in reducing both CNS and non-CNS relapses. So again, increasingly, it is a part of a number of protocols. Now, many centers in India do not have access to systemic methotrexate because they can't, measure the methotrexate levels. We have just recently, one of our study from our hospital has been accepted, where we just delivered, high dose methotrexate with a single value of systemic methotrexate. So if you have access to just even one value, if you can, it is feasible, then it may be possible to deliver it. But if it's not possible at all at that center, then the Capizzi's escalating methotrexate is again almost equivalent potency or efficacy as high dose methotrexate, and that is something that a center can consider. Initially the protocols used intensification very early, but now the philosophy of current ALL protocols is to use one block of delayed intensification, in the roughly about the 5th and 6th months. So I already mentioned this, that systemic or methotrexate in one form or another is really a very useful drug in pediatric ALL. It is non-myelosuppressive. So, but we have to look at, what is feasible for our own center. I'd just like to spend, a little time on maintenance, because a number of these patients may be, even though you may not have had to give the initial treatment, you may, inherit them during maintenance. And this is the longest phase of treatment. And it's I think the most neglected one. The backbone of maintenance therapy for the last 70 years continues to be oral mercaptopurine and weekly methotrexate. Now, one thing I'd like to highlight, that there is very interesting data that shows that the mercaptopurine should be submitted in the evening or night. And this has a significant improvement in survival. So it's amazing. Like I said, there has been no new drug, but we have learned how to use drugs better. When we give drugs once a day, we usually recommend them to give in the morning. So this is the only drug I know that has actually better efficacy in the night. We don't really understand why, but this is something that's called the chronopharma therapeutic, effect. And it's something interesting, something we are still trying to understand, but please recommend 6-MP in the evening or night. A number of maintenance protocols use monthly vincristine and 5 days, dexamethasone pulses. Not all protocols have that. And it's, questionable whether it really has any efficacy. But in our country, we still do that because it gives at least some reason for patients to come to the hospital. Otherwise, in maintenance they are really just sending you your CBCs, not coming because they think, well, nothing is to be done in the hospital, only oral, same medicine has to be continued. So it's very important to connect with them. And I think this really helps me in, have a constant continuity with the patients. I'd like to highlight that a number of centers during maintenance actually give folate regularly because, to prevent anemia, but that completely defeats the purpose of giving weekly methotrexate. So please avoid that. The rheumatologists do that all the time, but they are not trying to treat bone marrow disease. So in our case, it actually completely defeats the purpose of maintenance chemotherapy. And CNS sanctuary therapy is continued in terms of LP in most protocols during maintenance as well. So how does, maintenance chemotherapy, this is the only oncology protocol other than acute promyelocytic leukemia where we give this prolonged maintenance. So, how does this even work? And to be honest, pediatric oncologists are still trying to unravel the mystery of maintenance chemotherapy, but we know that it works. The proposed mechanisms are direct anti-leukemic effect, modulation of apoptic pathways, or perhaps the most important is to change a microenvironment of the leukemic stem cells by impeding anti-angiogenesis. So we don't really know how it works, but it definitely works. Again, an important thing to understand is that Asians, especially Indians, do not tolerate the same doses at 6-MP as the Caucasians do. So if we are picking up an international protocol, please be aware of this, that the recommended doses there are 75 mg per meter square, but most Asians cannot tolerate beyond 50 mg per meter square. And there are a number of pharmacogenomic reasons for that. The most important being NUT-T15. This you can test for this, and the other one is TPMT, which is much rarer in the Indian population. So for us, it is the NUT-T15, which will be positive in, present in about 15% of our patients. So be aware of this if you're managing a child with ALL. We would recommend strongly that it is titrated by ANC. So we aim to maintain an ANC between 750 to 1500. And if it is more than that, we keep on escalating the doses of 6-MP. Compliance, however, because this is such a long treatment, the child is well. Everybody, when we take a course of antibiotics after the 3rd, 4th day, we start missing some doses. So imagine for a family to give this treatment for 2 to 3 years, and the child is absolutely fine, running around, going to school. So compliance is a major issue. But we know that if there's a 4-fold increased risk of relapse if the compliance to maintenance chemotherapy is less than 90%. So I can't highlight this enough. And if you are managing these patients during maintenance, please ensure compliance. So how long do we need to give it? So the protocols vary between 2 to 3 years, and in some studies, boys are given longer, 1 year longer treatment than girls. But we know for a fact that if we make it less than 2 years, there's marked reduction in event-free survival. In fact, in one Japanese protocol, when they brought down to 18 months, the ALL outcomes fell down to 50%. So it was immediately suspended. And also that extending treatment beyond 3 years does not improve outcome, but increases late toxicity. So the optimal duration of entire treatment is 2 to 3 years. So who for ALL needs BMT? Because when a family is diagnosed with ALL, they go on Google and they think, well, you know, can I just do one transplant and get rid of this disease? So really, as of today, BMT is reserved for patients with relapsed and refractory ALL. And who do we call refractory? So if your MRD is positive at end of induction and of consolidation, whether you have high risk or standard risk disease. Even high risk or very high risk patients, if their MRD is negative, they would not go to transplant unless they relapse. So what are some of the novel approaches for relapsed or refractory ALL? Because most children are doing well with the drugs that we had 50 years ago. But yes, there are 10-20% patients that don't do so well. So these are some of clofarabine for B lineage ALL, nelarabine for T-ALL. Watizumab, that most of you will be very conversant with from myeloma, is actually a very good ALL drug, and it's increasingly finding its way in relapsed ALL protocols. But the other novel approaches are with immunotherapy. So we have monoclonal antibody. Rituximab is used a lot in the adult ALL studies. And for pediatric ALL, we have this drug blinatumomab, which we use for relapsed ALL, which is not responding adequately to chemotherapy. We have this available to us in India today, but it's prohibitively expensive. But the most interesting or engaging is the philosophy of CAR T cell or Chimeric Antigen Receptor T cells. Most of you would be aware of that because this strategy is being used virtually in every malignancies now. So the philosophy is that we take the patient's autologous cells and then they are in vitro manipulated to develop into CAR T cells, which will go back into the body and kill the leukemia using the immunogenic potential of these cells. So this is one of the first cases. She made it into New York Times. This was a child with multiply relapsed leukemia. All hope had been given up, and she was one of the first patients to enter a CAR T cell trial and continues to be a long-term survivor. Usually these novel therapies, they are a bridge to transplant. So you get them into MRD negativity and then you take them to transplant. But now we have data on CAR T cells that for a significant proportion of patients who actually could not get a bone marrow transplant continue to be long-term survivors. So this is the impressive results of CAR T cells, not just for ALL, but for CLL, NHL, and multiple myeloma. So just to conclude about ALL, which was the biggest section of my talk, is that with contemporary protocols, cure rates exceeds 80%, and most good centers in India, exceed these 80%. The paradigm of treatment is risk-stratified, response-adapted treatment, which is virtually being followed in all oncological conditions. Minimal, or now we call it measurable residual disease, is the most important prognostic indicator, and current treatment is almost entirely MRD driven. Increasingly, we are focusing on reducing late effects. So the current modern protocols, the cumulative doses of each drug is such that we do not expect children to have any long-term side effects. And the novel approaches I've already shared with you. So let's, it may be a little exhausting for you, but let me take you to now acute myeloid leukemia. This is the current outcomes, is showing through different eras, the outcomes for AML. So the story is not as impressive, but you can see that we are finally making some movement, and we are, more than 60 to 70% children can get cured with very intensive AML therapy. How do we classify it? There is the traditional FAB classification. And that really doesn't, because for all FAB subtypes, the treatment is the same except for AML M3 or APML. But the WHO classification increasingly is, determined by the genotype, or what is the genetic translocation identified in that subgroup. This slide just shows the difference between the childhood AML versus the adult AML, that definitely there is a little difference, and childhood AML actually is more favorable than adult AML as a whole. So currently we stratify AML as low risk if they have core binding factor, translocations such as 821 or inversion 16, and classify them as high risk if they have one of the high risk mutations such as monosomy 7, monosomy 5, deletion 5q, and certain other abnormalities, or they have blasts more than 15% after induction 1. All other patients are in intermediate risk category. So according to this classification, the biggest group is actually intermediate risk. But currently, measurable residual disease is again playing an important role in risk stratification. So, the big intermediate risk, if it is MRD negative, it goes into low risk. And if it is MRD positive, it is into high risk. So basically, we now use a combination of cytogenetics and measurable residual disease to risk stratify. The treatment essentially is induction and consolidation. The difference in pediatric AML is that unlike adults, we actually use 2 anthracycline-based courses. And the consolidation, similar to adults, is either intensive chemotherapy or stem cell transplant. Again, a different from adult AML is that pediatric AML does relapse in the CNS. So some form of CNS prophylaxis, at least 3 doses of intrathecal chemotherapy is given in virtually all pediatric AML protocols. Maintenance therapy does not play a part in pediatric AML protocols because randomized clinical trials have failed to show a benefit after the intensive chemotherapy then we give in induction and consolidation. But the exception to this is acute promyelocytic leukemia, where maintenance chemotherapy plays a very important role. So for induction, it's just very simple: anthracycline and cytarabine. Anthracycline could be donomycin, idarubicin, or mitoxantrone. And a lot of trials had evaluated which anthracycline is superior. More or less, it seems to be similar. And the toxicity is definitely more with idarubicin and mitoxantrone. So donomycin continues to be the anthracycline of choice for induction. Again, cytarabine, protocols have played with different doses, but 100 milligram per meter square once or twice a day for 7 to 10 days in induction remains the standard of care. Protocols have looked at incorporating other drugs, etoposide, 6-TG, but whether they really add anything, it continues to be debatable. And, so that is why 3+7 or 3+10, anthracycline and cytarabine continues to be the mainstay for pediatric AML protocols as well. The difference from adult protocols is that we have a higher CR rate. So 85 to 90% of children with AML will achieve, robust complete remission. But unfortunately, a proportion of them, 2 to 3% in the best centers, but in many other centers, especially in India, a very high treatment-related mortality. And that's why supportive care is a very, very important component. The estimated incidence of severe bacterial infection in induction is 50 to 60%, and estimated incidence of invasive fungal infection is in excess of 10%. So this is Western data. In India, I can say that severe bacterial infection would be close to 80% and fungal would approach 30% or more. So all patients of AML induction will be on antibiotic prophylaxis, antifungal prophylaxis, will need aggressive supportive care. The role of GCSF in AML induction continues to be actively debated. It does not show any overall survival advantage, but it may reduce the duration of neutropenia slightly. Consolidation, again, the backbone remains high-dose cytarabine with or without other drugs. It could be 2 courses or 3 courses. So for pediatric protocols, low-risk disease would get 2 courses and high-risk disease would get 3 courses. So who in pediatric AML actually should be sent for transplant? So patients with high-risk cytogenetics are recommended transplant if it is available to them. And again, we would then not recommend the full 4 or 5 courses. They can go for transplant after achieving remission, preferably if they are MRD negative. So on again, patients who are MRD positive after 2 cycles of induction may again be recommended to go for transplant. What about the monoclonal antibody gemtuzumab? Well, current data shows that actually patients who benefit most from this are those with low risk cytogenetics. So the patients with high risk cytogenetics in whom we are still struggling and we would like to add something like this drug actually do not benefit from the addition of this drug and have much higher toxicity. Just a brief word about granulocytic sarcoma or chloroma, because about 1% of patients will actually only have an extramedullary disease in the form of a solid tumor, and 11% may have chloroma but will actually have marrow disease at the time of diagnosis. All these patients, regardless of whether it is localized extramedullary disease, need to be treated as if they have AML systemically, and their prognosis, if they have only localized disease, is actually better than those with systemic disease. Most patients with such presentation will have the T821 abnormality, which is associated with a favorable prognosis. So should we irradiate these sites? Well, currently we know that radiation does not improve survival in patients who have a complete response to chemotherapy, but it may be necessary if patients have an incomplete response or have a local recurrence of chloroma. So what about the point of measurable residual disease in AML? Well, it's much more challenging to do. So most labs currently do not offer this because it needs very specialized techniques. And there are reasons for that, because the treatment itself in ALL, we are just seeing what is happening in the beginning, the diagnostic marrow, and we just compare the end of induction marrow. But in AML, the treatment, there can be clonal selection, it can be an immunophenotypic shifting. So it's very difficult to do. PCR-based MRD may be feasible in 40 to 50% if they have an identifiable translocation like I have described. And if we had NGS, we could find a marker in 90%. But in all patients, it's just technically more demanding for the lab, and only very specialized labs should be able to do it. So you can see that yes, prognostically, it makes a huge difference. If you are MRD negative or MRD positive, your overall survival and your event-free survival dramatically different. So, those, if you have MRD negative, but the cutoff in AML is less than 0.1%, while in ALL it was 0.01%, your chance of relapse would be only 17%. But if it is MRD is more than 1%, your chance of relapse is extremely high. So the current pediatric protocols, the AML 15, the decision making is to an extent MRD driven. This is the COG, the previous one was the UK strategy. So patients who are MRD positive actually will be recommended transplant. The problem is that we still do not know if that will translate into improved outcome. So that is, that is where the dilemma is, that we can do MRD. Okay, it is very specialized, but we will do it. It prognosticates. But whether escalating treatment actually improves outcome, like we know for sure in ALL, that evidence is still we are working to find. This is again for adults. MRD in AML is equally prognostic. You can see how the event-free survival and overall survival are remarkably different for patients who are MRD negative or MRD positive. So even, the problem is that the MRD positive do badly even when they transplant them. And that is where the dilemma is about doing it. So what we do know is that about 40% of AML patients will be MRD positive at the end of induction. It's definitely prognosticating, and they will have, even if we take them to transplant, if MRD is positive, survival is, inferior. And therefore, if we are going to take them to transplant, again, we should endeavor to make them MRD negative. So what are the current guidelines? Should we be monitoring MRD? Well, this is the European Leukemia Network report from 2018. This is a consensus statement which says that this should be the standard of care. To do MRD in AML, but most of our centers we are not doing. And it is not just us. This is such a controversial consensus that even within the same journal, there was a commentary on that is there consensus about this? and this is still, debatable, because we don't know if we will change their outcomes by increasing treatment. So currently there is a very interesting study going on in UK to monitor or not to monitor. So here their patients are randomized. This is both a pediatric and adult study. So it is up to the age of 50, and patients are randomized to either go for MRD monitoring or not go for monitoring, and the intervention for MRD positive patients is left to the discretion of the treating doctor. And I think this study will very nicely show whether this will make a difference or not. Just a couple of slides about acute promyelocytic leukemia, which is a completely different disease altogether. Usually we know that it presents with universal coagulopathy, has unique morphological characteristics. It has the classical, translocation of the RARA oncogene of the 1517. But the most interesting thing is the unique sensitivity to ATRA and the pro-apoptotic agent arsenic trioxide, which are currently the backbone of APL therapy. So pediatric APL is very similar to adult. For APL, more than 10,000 is considered to be high-risk disease, and treatment is escalated for them. So more children are likely to actually have high-risk APL or the microgranular variant, which again doesn't do so well. So the current treatment for APL is actually, the backbone is ATRA and arsenic with some chemotherapy, especially for patients with high-risk disease. But the chemotherapy or the anthracycline has been reduced significantly, because you can see, like in this study, with just very little anthracycline and arsenic and ATRA, the overall 3-year survival was 94% and event-free survival was 91%. So these are, these are amazing outcomes. And arsenic, I think we should take pride that the arsenic data predominantly came from India, from wonderful studies done at CMC Vellore, and this has actually shaped APL therapy across the world. So what about new therapies? So a number of targets are currently being evaluated in AML, and maybe in the years to come they will play a role, but none of these are actively used at the moment. Come to my final part of my presentation, which is what are the current, in the current era, what are the indications for radiation in ALL and AML? So I'd like to start by saying that, I showed you the journey of ALL where we, increase, and the biggest quantum of improved survival is actually attributable to cranial radiation. So a big hats off to our, radiation colleagues, because initially we could get patients on remission, but every child relapsed in the CNS. So cranial RT, which was an innovative thing at that time, really transformed the outcomes for childhood ALL. But over a period of time, we recognized that we are actually paying a very heavy price in these young children for this, for cures and, in terms of late effects. And over the subsequent eras, when the systemic therapy has improved so much, the role of cranial radiation has completely shrunk. So this is, a lot of that we know from about, late effects has come from this ongoing childhood cancer survivor study. And we know that in ALL, most of the long-term effects were attributed to cranial RT in terms of neurocognitive, endocrinopathy, and second neoplasms. So we have learned in pediatric oncology that in diseases that we are treating, we have to have a very fine balance in terms of optimizing outcomes and paying, limiting the price of cure. And this is what we learned about cranial RT, that there was a very high incidence of endocrinopathy if young children received. So this shows just the growth curve. The first one shows complete growth failure for somebody who received, a cranial RT very early in life compared to a normal child. And the most devastating of all, the second neoplasms. In terms of neuroimaging, we know that there are a number of changes. It can cause neurocognitive impairment, late dementia, vascular abnormalities, leukoencephalopathies. So, a lot of neurological side effects, and the most devastating of them being a second malignancy later in life. So today we know that with systemic therapy, and this is, we may not need ALL, may not need RT for most of our patients. And this was a retrospective analysis of 10 collaborative study groups, the COG, AIEOP, BFM, and which were giving radiation to a subgroup. So some centers in India will still give it to T-cell disease, especially if they have white cell count more than 1 lakh, will give to older children. So this meta-analysis showed that actually there was no effect on event-free or overall survival in any scrub group except for those with CNS disease at diagnosis. So currently most centers will reserve cranial RT for children who have CNS disease at diagnosis. And even in T-cell disease, we know now that it is with contemporary treatment we can get away without cranial RT. So at St. Jude's there is no cranial RT. For COG, it will only be CNS disease at diagnosis. For UKLL protocols, even with CNS disease, they will see that if after 2 doses of IT methotrexate, the blasts don't disappear, only those children will receive cranial RT. And again, some other protocols, no cranial RT, even for those with CNS disease. But it has a role in other situations. So for BMT conditioning, cyclophosphamide TBI continues to be the commonest conditioning regimen. And we need the help of radiation oncologists there. We need help for testicular leukemia. Again, previously all children with leukemia, testicular leukemia, would get RT. But now if at end of induction there is active disease, they will get RT. But all who have testicular relapse will receive radiation. For granulocytic sarcoma, I already mentioned that only those who have incomplete response to chemotherapy will need local radiation. So, I'd like to just summarize by saying that there is an old African saying that it takes a village to raise a child. And similarly, we believe in pediatric oncology that it takes a whole village or a whole community of specialists to treat a patient with childhood cancer. Unfortunately, in India, here this is a Western paradigm, but in India, as an oncologist, as a clinical oncologist, maybe many of these roles will be filled by just one person, which may be you. But we must remember that when we treat with children with cancer, childhood is a period of joy. Yes, we have to treat cancer, but it does not mean that it should be devoid of all happiness. So as pediatric oncologists, we'll try and put in special memories, celebrate their little events, and celebrate their successes. So we encourage children to come back to our OPD on follow-up and bring up whatever little victories they have made in life, makes us motivated, keeps our motivation on, and keeps their motivation on. So, I'd like to end here, and thank you so much for your patient listening.